Here is the second part to our orthoptic drug drops, and more specifically, the adrenergic drugs. So we'll get ourselves familiar again with the diagram. The top part is going to be our nerve ending, and the bottom part is our effector organ. And for sympathetic, our effector organ is the iris dilator and Mueller's muscle. The first drug that we have is our direct-acting adrenergic. So we have norepinephrine in that presynaptic area, gets released into the synapse, and then the direct-acting adrenergic also is in that synaptic area. Normally, without that direct-acting drug, the norepinephrine would go into our adrenergic receptors, which can be alpha 1, beta 1, or beta 2. But with the direct-acting adrenergic, the direct acting drug goes into those adrenergic receptors and mimics the norepinephrine. So the adrenergic drug directly interacts with the postsynaptic alpha 1 and beta receptors on the target effector organ, activating the organ in a similar fashion as norepinephrine would. In summary, there's 3 different names that you can do for this drug. One is direct acting adrenergic. We have sympathetic agonist and sympathomimetic. In summary, it interacts with the adrenergic receptor, alpha and beta. It activates that effector organ, and it mimics what norepinephrine does, which pupillary-wise, we get a pupil dilation, which is the stimulation for it. And then some examples, the one we commonly use is the phenylephrine or neosifrin. Next one we have is indirect acting adrenergic. Now this one has 2 different types that we can do. The first type here that we'll talk about is the increased release of norepinephrine in the synaptic area. So we start off with our norepinephrine. We produce more norepinephrine super fast and more till we have a whole bunch in our synaptic area. They bind to our effector organ, and our effector organ is nice and happy. So this one just increases the release of that norepinephrine. The second way an indirect acting adrenergic drug can react is by inhibiting the reuptake of the norepinephrine from the synapse. So we're producing norepinephrine, we're producing more and more, and then our effector organ's happy because it has norepinephrine, but that norepinephrine will not be able to get reabsorbed into that neuron. So it just kind of sits and waits in the synaptic area, which creates quite a bit of norepinephrine in that area. So in summary, that is a direct-acting adrenergic. We can either increase release of norepinephrine or block the reuptake of norepinephrine, which causes pupillary dilation through stimulation. And our 2 examples are our cocaine for Horner's testing and then the Paradrine. The last one that we have is our anti-adrenergic pathway. So we have our norepinephrine again in our nerve. It gets released, and then we have the anti-adrenergic drug coming in. And just like with the other ones, it blocks the receptor sites on that effector organ, which causes not a lot of norepinephrine to get in there, not enough for the effector organ to be happy. That's why it has a frowny face. So it just blocks that norepinephrine and the epinephrine from activating that effector organ. So simplistically here, the beta adrenergic blocking agents prevent epinephrine and norepinephrine from applying receptor sites on the cell membrane. This action alters cell function, normally stimulated by epinephrine and norepinephrine, and then according to the number of receptor sites occupied by the beta blocking drug. So that's kind of what this one does. In summary, there's 3 different names that it goes by: anti-adrenergic, sympathetic antagonist, and the sympatholytic. It does pupillary constriction by relaxation, and the one that, or the 2 I guess we commonly use would be timolol and propranolol.